You can start.
All my exam going postgraduates, they are there to help her actually. That was what I was about to say.
Yes, yes, she needs all that support.
Yes, sir. Yes.
So, welcome all of you. We are about to start the 9th episode of our APOS ARC short cases webinar. We are doing this every last Friday of every month. This month, we have as examiners Dr. Ansua Ganguly Kapoor. She is the head of campus LV Prasad Eye Institute at Vijayawada. And we have Dr. G. Sirisha. She is a professor and head of department of NRI Medical College and General Hospital, Guntur. So today, first I welcome both the examiners. And we have our ARC members, Dr. Tarkeshwar Rao is here. And we have Dr. Kailan Raju. Kailan Raju is also today's mentor. Welcome, Dr. Tarkeshwar Rao and Dr.
Sir. Good evening, sir.
Kailan Raju. We have Dr. Sivaprasad, the treasurer of Andhra Pradesh Ophthalmological Society. Welcome, Dr. Sivaprasad. We need your financial support for all this. You are most welcome.
Sure. Thank you.
And today's presenters are Dr. V. Kritika. She is a final year PG from Department of Ophthalmology, Kurnool Medical College. And we have Dr. H.M. Chetan Kumar, second year DNB PG from Sodasni Eye Hospital, Guntur. So, if Kritika is ready. You have to unmute yourself. Kritika, are you ready?
Yes, sir. I am ready, sir.
Yes, if you are ready, I think we'll start with your case. She is going to present a case of ptosis. Over to you, Kritika. Please share your screen and you can start your presentation.
Sir, is my screen visible, sir?
No, not yet. Welcome, Dr. Nivedita. Okay, Chetan Kumar, can you share your screen? Dr. Chetan Kumar is going to present a... Okay, Kritika is... Okay, fine. Kritika is... share the screen. Start presenting, Dr. Kritika. Unmute yourself and start presenting. Unmute yourself. Video technologies, please unmute Dr. Kritika. Yes.
Am I audible and my screen is visible, sir?
Yes, your screen is visible and you're audible. You can start your presentation now.
Yes, sir. Thank you, sir. Good evening, everyone. Myself, Kritika, final year resident from Kurnool Medical College. I'm going to present a case under guidance of Dr. Kailan Raju, sir, Assistant Professor, Kurnool Medical College. And my HOD is Dr. B. Yugender Reddy, Kurnool Medical College. So I'm going to present a case on a 13-year-old girl from Yaminganur presented to RHOP with the diminution of vision in right eye since 1 year and drooping of right eyelid from birth. History of presenting illness. So the girl's vision has started to reduce in right eye since 1 year. There is gradual and progressive diminution of vision and it was improving on retracting the right upper lid. The girl's mother initially observed unequal size of her child's eyes from birth. Later, she observed drooping of right eyelid, which was increasing with age. There is no aggravating or relieving factors. There was history of multiple hospital visits since birth for drooping of right upper lid and was advised for surgery after 5 years of age, but the parents did not follow it. It is not associated with jaw movements or abnormal ocular movements. There is no diurnal variation noted. There is no history of trauma, no history of previous ocular surgery, no history of eyelid swelling, no history of dysphagia or change in voice, no history of recurrent rubbing of eyes, no history of use of any topical medication like topical steroids, no history of diplopia, no history of usage of any rigid contact lens, or no history of lack of sweating is noted. Past history is not significant. Coming to family history, history of second degree consanguinity marriage is noted. Here I want to elaborate on the family history. So the mother had given birth to 4 children. Among them, the elder child had come to her OP with ptosis. And we had found that her twin sister, the right side picture, has also ptosis, but with of lesser severity. So when we asked for the photographs of all her children, it was observed that her last two children had also started developing ptosis. This is the picture received from the parents. Apologies for poor clarity of the picture, sirs. Coming to birth history, the child was born out of cesarean delivery and it was uneventful. Menstrual history, the girl has attained menstruation 2 months back with regular cycles. The girl is not on any medication right now. Coming to ocular examination, facial asymmetry is noted with the drooping of right upper lid. Head posture is straight, chin is elevated, eyeball is orthophoric, extraocular movement is free and
What
full.
kind of, excuse me, can I ask questions, sir?
Yes, ma'am.
So
Yes,
what,
yes, you can ask questions anytime.
okay. So what kind of head postures do you expect in this case?
In ptosis, if it is associated with any third nerve palsy, there will be head posture tilted to the opposite side, head turned towards opposite side and head tilt towards the same side, madam.
Third nerve palsy.
Yes, ma'am.
Third nerve palsy or head tilt?
Head turn towards opposite side, ma'am, and head tilt towards same side, madam, in case if any recti muscle involvement.
Okay. Okay, continue.
Yes, ma'am. Coming to right eye, visual acuity is hand movement for distance, and after retracting the upper lid, it is 6-6. Near vision is N6. Eyebrow is at little bit of higher level than left side. Eyelid, there is drooping of upper eyelid noted. Lid crease is absent. Conjunctiva is normal. Cornea, it is of normal shape and size. Corneal clarity is clear. Sensations are intact. Anterior chamber is of normal
Now
depth.
you can tell the examination of the eyelids. You can tell the ptosis evaluation here.
Okay, madam. Coming to ptosis examination of right eye, palpebral fissure height was examined in all three gazes. In primary gaze, it is of 4 mm. In down gaze, it is of 5 mm. In up gaze, it is of 4 mm. Palpebral fissure length is of 28 mm. Marginal reflex distance, that is MRD1, is minus 2 mm. MRD2 is 6 mm. And marginal limbal distance is 3.5 mm. LPS action, that is lid excursion, which is done by Berkey's method, is of 4 mm.
Can you explain how will you do LPS action? What is that Berkey's method?
Yes, madam. So we'll have to ask the child to sit in upright position with her back supported along the wall, and we'll ask the patient to look at the 660 target in well illuminated room with a diffuse illumination over the glabella. We'll have to ask the child to look from extreme down gaze to primary gaze, and we'll have to assess the lid excursion with help of ruler, madam.
Is it what will you do about the frontalis?
Frontalis action has to be removed by placing the thumb above the eyebrow, madam.
That is most important. You are talking about room illumination. That is not
Yes.
important. What is important is you will block the frontalis muscle by putting your thumb.
Yes,
And then
madam.
what will you do?
Then we'll ask the child to look from extreme down gaze to up gaze, madam. By nulling the effect of frontalis, then we'll measure the excursion, madam.
So what is the normal LPS action?
Normally, it is 12 to 17 mm excursion has to be there, madam.
So in your case, both eyes they are having ptosis or only one eye? Normal is around 15.
Yes, madam.
So in the left eye also you wrote 10.
Yes, madam.
Okay.
Marginal crease distance. Since crease was absent, I was not able to examine the marginal crease distance. Vertical tarsal height is of 7 mm.
No, go back. So now you have measured the palpebral fissure height.
Yes, ma'am.
In a primary gaze, but in the down gaze it is more. What is the cause?
In case of poor levator relaxation, there will be lid will be lagging in the down gaze, madam.
So why there is a lid lag?
Because of poor dystrophic levator muscle, madam.
So that muscle is, there is a dystrophy in the muscle.
Mm.
Okay, so there is a lid lag.
Yes, madam.
Okay. So what is this marginal crease distance?
From the upper lid margin to the first visible crease, we'll have to measure the crease, madam. Crease is nothing but the insertion of LPS onto the skin, madam.
Why crease is absent here?
Because of the underdevelopment of the LPS and dystrophic LPS, the crease is not visible, madam. It is not exactly attached to the skin, madam.
So what is the origin of the LPS and where is it inserted?
LPS is originating from the lesser wing of sphenoid, and it will go under the roof of the orbit over the cone of muscles. And when it enters into the eyelid, it will get inserted over the anterior surface of tarsus, madam. The medial horn will get inserted along the medial canthal tendon, and lateral horn along the lateral canthal tendon.
No. What is the superficial part? What is the deep part? Where are they getting inserted? Where is the superficial part of the LPS getting inserted?
Yes, ma'am. Superficial fibers are getting inserted over the skin, madam, whereas deep fibers are getting inserted onto the anterior surface of tarsus, ma'am.
So what is this aponeurosis?
Aponeurosis, it is the fibrous extension of the LPS muscle.
So where is it inserted?
It is getting inserted onto the tarsus, madam.
Tarsus. The aponeurosis, where is it inserting? So it is inserting in the medial and the lateral palpebral ligaments, okay?
Okay, ma'am.
Continue. You
Yes.
can, if there is no lid crease, you can measure a marginal to fold distance also can be measured sometimes.
Okay, ma'am.
Hmm.
Lid lag on down gaze is present, and there is frontalis overaction. On ice pack test, there was no improvement in ptosis. On fatigability test, there was no change in ptosis. Jaw winking phenomenon is absent. Bell's
How will you do this fatigue test?
We'll have to ask the patient to look in up gaze for about 60 seconds, madam, and we'll have to note any change in the ptosis, whether improvement or it is still this change, madam. Same.
You will see improvement. In
Yeah,
which case,
whether it's getting worsening or it is remaining the same, we will see,
so
madam.
in which case you will see worsening.
In case of myogenic ptosis like myasthenia gravis, there will be worsening, madam.
Okay.
Bell's phenomenon is good in right eye. Lag of thalamus is absent. Tear film assessment was done by Schimmer's test, which is found to be 25 mm, and tear film breakup time is noted to be of 15 seconds.
What is the importance of doing a tear film assessment in a case of ptosis?
In case of any ptosis surgery, we'll have to evaluate the tear film to look to rule out any dry eye disease, madam. In case of dry eye, we should not go ahead with surgery.
In this patient, do you expect to see any dry eye in your 13-year-old girl?
No, madam.
So if it is an elderly female, then you want to do a dry eye. Okay.
Okay.
So now you are telling Bell's phenomena is good. What is
Yes.
that Bell's phenomena? How will you grade it?
Bell's phenomenon is the upward and outward rotation of the eyeball, madam, on lid closure. It is a protective mechanism. So grade one, if there is more than 2/3 of cornea is covered under the lid, it is good, madam. Fair Bell's is 1/3 to 2/3. If less than 1/3 of cornea is under the lid, then it is poor Bell's, madam.
Okay. So what is this jaw winking phenomena?
In case of any aberrant regeneration from lateral pterygoid muscle to levator LPS muscle on chewing or lateral movement of mouth, there will be improvement in ptosis.
Okay.
Coming to fundus examination, in both right eye and left eye, media is clear. Optic disc is of normal shape, color, and margins. Cup disc ratio is 0.3:1.
Hi, Kritika. I want to ask one question. So, how do you grade Marcus Gann jaw winking phenomenon?
Marcus can jaw winking. If there is less than 2 mm of ptosis improvement, it is Mild Marcus gun jaw winking, madam. If there is 2 to 4 of improvement in ptosis, it's moderate. Severe is more than 5 madam.
So what do you do? On doing what you note the change?
We'll ask the child to chew or do lateral movements of mouth, madam.
Yeah, so what is the name of this test? So basically, you do the movement which is eliciting ptosis, usually the side to side movement of the jaw. You do it against resistance. You do it against resistance and see how much is the excursion of the eyelid.
Okay,
And the grading, what you said is correct. It is only, you just need to know how you do it. This is known as the reinforcement test.
okay, madam.
Okay, go on. And also I just wanted to add there a levator insertion. The 5 insertions of levator is also something you need to know because that's a very commonly asked question for your exams.
Yes, madam. Yes, madam.
So go back and read about the 5 insertions of the levator.
Okay, madam.
Go on, Kritika.
Blood vessel is of normal AV pattern, 2 is to 3 ratio in both eyes. Macula foveal reflex is present. Background retina is normal. So my provisional diagnosis is simple unilateral severe congenital ptosis of right eyelid with poor levator function. My differential diagnoses are blepharophimosis, epicanthus inversus syndrome, third nerve palsy, third nerve misdirection syndrome, congenital synkinetic ptosis, Horner syndrome, chronic progressive external ophthalmoplegia.
How will you differentiate your condition from a Horner syndrome?
Horner syndrome, along with ptosis, it will be associated with the meiosis and anhidrosis.
Meiosis, anhidrosis, and
Enophthalmos heterochromia iridis.
so go back to your diagnosis. Diagnosis. Diagnosis.
Yes, ma'am.
We are only seeing the fundus. Diagnosis. Yes. Why do you call this as a simple?
It is not associated, it is an isolated ptosis, so I have called it a simple, madam.
So what are the things you will see? So one is a blepharophimosis, Horners. All these are if these are present, you will call them as.
Complicated ptosis, madam.
So go back to the diagnosis. Now, poor levator function. Now, what is the management you want to do? What will you do for this case?
Since it is a severe ptosis with poor levator function, I would go ahead with frontalis sling, madam. Brow suspension surgery.
Frontalis sling.
So,
Levator function is less
Kritika,
than. Yes,
Kritika,
ma'am.
before we go to the treatment, so you said this is a congenital ptosis. The congenital spelling is wrong. Like in the history, is there anything which you said was not going in favor of congenital ptosis? Very nicely, you have taken the history, all the negative history you have told correctly, but something went against congenital ptosis. What was that? Can you go back?
Yes, ma'am.
So you talked about the onset being from birth, 13-year-old onset from birth, perfect, going in favor of congenital. But what about the progression?
It was progressive, madam.
So how is a congenital ptosis usually? Is it stationary or classically is it stationary or progressive?
Classically stationary, madam.
Yeah, so it is unlikely that it will progress. So this is going against. So maybe it will be a good idea to ask the patient to show old photographs, to review her old photographs.
Yes, madam.
There you can assess. Here, which one is this girl?
The left side, madam. Pink color.
Okay, so like not long back. This is a recent one only, I think.
Yes, madam.
Yeah, so you can ask for a level like when the child was 3, 4 years and assess for yourself because you won't see any change. Congenital ptosis is classically stationary. The other thing is like, what do you expect? Congenital ptosis to be more commonly sporadic or hereditary?
Hereditary, madam.
No. So congenital ptosis, unilateral congenital ptosis are typically sporadic. 80% are sporadic. Only 20% can be familial. So this is a rare situation which you are in. That it is familial, all the sisters have it. So it falls in the 20%. But commonly unilateral congenital ptosis, 80% will be sporadic. That's the rule of thumb.
Okay,
Okay.
madam.
Now let us go to the treatment part that madam was asking. So what is the LPS action, Kritika?
It is only 4 mm, madam, excursion.
4 mm. Okay. So but you just talked about that the traditional teaching for all of us have been that less than 4 mm, we will do a tarsofrontal sling. More
Yes,
than 4 mm, we will do a levator resection.
reception.
But
Yes.
anything else from your, like anything else you have read about that we can do for this child that now that you know the action is 4 mm? Yes, tarsofrontal sling is an option, but what else can be done?
Levator resection can also be tried, madam, because lag of thalamus is more common with the frontalis sling surgery, madam. So we can try levator resection also.
Yes. So what you need to tell in your exam is ki traditionally less than 4 mm tarsofrontal sling is the surgery of choice, but there is a lot of current evidence that a supramaximal levator resection. So just a normal levator resection won't work for this patient. So you need to do a supramaximal levator resection where you go up till the vitnals and hitch the tarsus to the vitnal so that you can get the maximum benefit from whatever action of the levator is there. So
Okay,
Sekhi tarsofrontal sling and supramaximal levator resection is also possible.
okay, madam.
Okay.
Yes, madam.
Did
Yeah.
you check the extraocular movements?
Yes, madam. Extraocular movements was free and full in all cases.
Okay.
Okay. So tarsofrontal sling, what are the sling materials you know of, Kritika?
Silicone rods, fascia lata can be used, madam. Even silk or meshline mesh can be used.
Okay.
Braided suture can also be used, madam.
What else?
Proline, madam, silk proline, fascia lata,
Okay. What else?
Gore-Tex, madam.
Gore-Tex. So what is Gore-Tex? Okay. So now good. You have mentioned many of them. Ethibond is one more suture material which
Yes,
we use very commonly for smaller kids.
yes,
And
madam.
which one is the gold standard as per our textbooks?
Silicone rods, madam.
No, no, no.
No, no.
So we all have been traditionally taught ever since our residency days
Fascialata.
that yes,
Okay, madam.
fasciolata is the gold standard because it is autogenous. You are not getting a external material there. It is
Oh,
patient's own body tissue that we are using.
okay, madam.
Okay, so Kritika, if I can ask you, why is this not a aponeurotic ptosis? So the two most common types of ptosis are congenital and aponeurotic.
Mm.
So I'm saying ki this is aponeurotic. So how do you counter me? Can you just start from the history and differentiate a congenital from aponeurotic?
Yes, madam. So aponeurotic, it will not be present since birth, madam. History, according to history. And coming to examination, lit crease will be present, but it will be present on a higher level, madam.
No, wait, hold on. Kritika, so history you said since birth. So what will it be for aponeurotic usually?
If it is present since birth, following any birth trauma with forceps delivery, also it can be congenital aponeurosis.
Very rare, but what is the usual case scenario for aponeurotic ptosis in our daily OPDs? What will we see? What is the age group?
Senile.
Aponeurotic. Yes, yes. So it's a usually elderly patient. So you talked about the age of onset, progression. How is congenital? How is aponeurotic?
In congenital, it will be stationary, and aponeurotic, it will be progressive ptosis.
Very good. Now go on to the clinical finding that you were mentioning
In eyelid examination, lid crease will be present, and the crease position will be at a higher position, madam.
for aponeurotic.
Yes,
Good.
ma'am.
So receded eyelid crease because the levator
Disintegration.
aponeurosis is disinserted. So you will see it going higher up. Very good. Congenital, what will it be?
Congenital lid crease will be absent, madam.
Absent, or it can be very faint based on how much levator action is there. So it's an indicator, a surrogate indicator for the levator action. Very
Okay.
good. So lid crease difference you have talked about. What else?
In aponeurosis, there can be multiple lid creases also, madam. And on down gaze, there will be lid will be in lower position, whereas in congenital ptosis, there will be lid lag on down gaze, madam.
Congenital ptosis, down gaze, what happens? Lid lag,
Lid,
correct. What
madam.
happens in aponeurotic?
The lid will be pulled even more down, madam.
Lid drop.
Lid drop, yes, madam.
Very good. Lid lag versus lid drop. What else? What else? You're doing very good, Kritika. What else? One more. What about the levator action? How is it in congenital and how is it in aponeurotic?
Levator action will be poor in congenital, whereas it will be good in aponeurotic.
Very good. So these are the majorly the points by which you differentiate congenital versus aponeurotic.
Yes, ma'am.
Rasimisha, you want to ask anything?
Last 4 minutes for this case.
Okay, so go to the differentials, Kritika. So quickly, can you tell me how did you rule out these differentials? Why is this not a BPS?
In blepharophimosis epicanthus inversus, there will be, along with ptosis, there will be shortening of horizontal palpebral length, madam, and there will be epicanthal folds. So that's why I have ruled out, madam. There will be telecanthus also. Whereas in third nerve palsy, there will be down and outward movement of eyeball, and eye pupil will be dilated, and there will be restriction of movements, madam. In third nerve misdirection syndrome and congenital synkinetic ptosis, there will be
Just hold
abnormal
on. Pupil may or may not be dilated. It can either be pupil involving or pupil sparing.
sparing.
Okay, no,
Yes.
but typical is the extraocular motility limitation that we will see in these cases. Good. Go on.
Yes.
Hmm.
In third nerve misdirection syndrome and congenital synkinetic ptosis, there will be abnormal movements associated with the ptosis, madam. In Horner syndrome, along with ptosis, there will be meiosis and anhidrosis, enophthalmos and heterochromia iridis. In chronic progressive external ophthalmoplegia, it is autosomal dominant, and it should be present in mothers also. And mainly, there will be restriction of extraocular movements.
What else? So CPO is a myopathic ptosis. What else? Apart from extraocular motility limitation, what else will you see?
If there is
CPO is
abnormality of
also very common as a short case or long case in your exams. Yeah. So what are the typical features?
it is a mitochondrial disease, and typically it will be seen in mothers, ma'am.
Clinically?
Bilaterality is
Clinically, how do you diagnose? Bilaterally. Good,
bilateral.
good. What else?
In fundus also there will be pigmentation seen in the peripheral fundus, ma'am.
Can be, not in all cases. In which cases do you see retinitis pigmentosa like feature in the fundus?
In Kearney-Sayre syndrome, ma'am.
Very good. Kearns-Sayre syndrome, yes. But all CPO, what is the common thing? One you talked about, it is usually bilateral. It is progressive. Extraocular motility is majorly limited.
Yes, ma'am.
Ptosis is usually severe. But
Yes.
what is the fifth thing, which is very important and is a indicator of this disease? What about bells?
Poor bells will be there, ma'am.
Correct. So this is the classical feature. Word bells you will have to say when we talk about CPO, because
Okay.
the next thing will come. The examiner will ask you how will you treat this patient. Can you do a levator resection?
No, ma'am.
So what is the classical uh, treatment for CPO?
Frontalis sling will advise, ma'am, in such
No,
one.
no, no. First, you will have to say for CPO, traditionally, no ptosis surgery because they have poor bells. If you do ptosis surgery, very high chances of exposure keratopathy. So,
Yes.
say crutch glasses. Crutch
Yes.
glasses are the treatment of choice, is
Okay.
what you need to answer for your exam. If they are not comfortable with crutch glasses, then only we do a tarsofrontal sling, that too with silicone and with predetermined undercorrection. We just cleared the visual axis. So that is
Okay.
the treatment of CPO.
Okay.
Okay, I think we are done with our time. So thank you, Kritika. You did a fantastic job. Very nice history taking and workup.
Thank you, madam.
Ritika, can you stop sharing?
Yes, sir.
You've done your case very well. Thank you.
Thank you, sir.
And good discussion by Dr. Sirisha and Dr. Ansuva. So let us move on to the next case. Dr. Chetan Kumar, are you ready? Oh, he's started sharing also. Good.
Yeah.
You can start your presentation.
Good evening, everyone. Today I'm presenting a 13-year-old boy student who is residing in Guntur came to us in May 2026 with complaints of left eye pain, defective vision, difficulty to look at light, watering since 4 days of duration. Coming to history of presenting illness, patient was apparently healthy 4 days ago when he suddenly developed pain in the left eye, difficulty to look at light, watering, and defective vision, and it slowly increased over the 4 days when he presented to us. The pain was constant throughout the day with the radiation to left forehead and ear region. Pain was of moderate intensity and gradually increased over the 4 days. Pain increased on looking at bright light and was associated with the watering. Vision was initially good but gradually started reducing day by day. There was no history of colored halos, no history of trauma, no history of fall of foreign body, no history of ocular surgeries, no history of usage of glasses, no history associated with severe headache or vomiting or abdomen pain. There is no history of fever, no history of burning micturition, no history of exposure to pets and recent travel. There was a history of bilateral knee pain and exertion since 1 month, not associated with the lower backache. There is no similar episodes in the past. Coming to personal history, is not a known case of diabetic or hypertension, no other systemic disorders. He takes a mixed diet, bowel and bladder habits are normal, sleep and appetite are within normal limits. Coming to family history, he was born to non-consanguineous marriage, born at full term, normal developmental milestones. He is a single child, no siblings present. His grandmother has a rheumatoid arthritis. Coming to general examination, patient was conscious, coherent, and oriented to time, place, and person, moderately built and arranged, favorable at the time of examination. No pallor, icterus, cyanosis, clubbing, edema, lymphadenopathy. Vitals are within normal limit. Coming to systemic examination, all other systems are within normal limit. Coming to ocular examination, I would like to examine the affected eye, left eye first. Uh, Unaided visual acuity is in the left eye is 6 by 18, near vision is 10-12. There was no improvement further with the glasses. IOP with NCT at 2:30 p.m. It is 12 mmHg in the left eye. Face is symmetrical, no skin lesions seen on the forehead. And the reflex is visual corneal reflex central and orthophoric. Coming to orbits, which are normal in the left eye, lids and anexa shows mild upper lid edema, and the conjunctiva shows circumcorneal congestion present. Sclera is within normal limit. Cornea shows fine capies on the endothelium in the alt triangle with the diffuse endothelial dusting. Anterior chamber shows 3 plus cells, early fibrin in the pupillary area, yellowish white in color, hypopion in 1/4 of the AC present. There is no shifting of hypopion noticed. Coming to iris, which is a smooth and muddy
Can you
iris.
show the
Pupil,
picture?
yes, ma'am. This is a
Where is the
diagram.
photograph?
Yes, ma'am.
Do you have the
We
photograph?
didn't take
Ah,
on the day 1 and day 2. Patient was not cooperative with the photograph. We took after 3 days of after treatment with atropine and prednisone treatment.
You said
this is
one fourth of AC, hypopion.
Yes, sir.
It subsided in 3 days.
Yes, sir, with prednisolone acetate, it will subside, sir. Steroids, topical steroids.
So this image, you cannot see any findings. So show me your drawing.
This is a drawing showing the front view on the cross section.
Your hypopyon doesn't look like 1/4 of the cornea. And pupil is irregular.
Yes, ma'am. Due to posterior syncytia, segmental posterior syncytia, people was irregular, ma'am.
After 3 days, it became round.
Yes, ma'am. Because it is acute onset of posterior syncytia, that syncytia got broken with
In 4 days, where do you see posterior syncytia in acute iridocyclitis or in a chronic iridocyclitis?
it will seen in acute also, ma'am. Chronic also it will be present, ma'am.
So what happens to the pupil in acute iridocyclitis? It is small or large?
Pupil will be small, ma'am. Due to inflammation, the iris will be boggy and swollen, ma'am.
The pupil should be small. So this kind of picture will come after you will start dilatation. Okay, you have drawn a festooned pupil there.
Yes.
When you are presenting, it is better you will have a slit lamp picture in the initial day. Then we also can see. Okay, you should have documented it. Okay.
Yes, ma'am. Yes, ma'am.
So go back to your.
He must have decided to present this case after 4 days.
Yes, sir.
Yeah, Chetan, I have a basic question for you. So, what
Yes,
what
ma'am.
classifications, grading system did you use for the cells and flare?
Ma'am, standardized UN EVT's nomenclature of cells, we have uh, 0 to 4, grade 4, ma'am. We'll examine the patient in the dark room with a slit size of 1 into 1 mm with high magnification and high illumination. We'll grade the cells according to the counting of cells. 0 means less than 1, and 0.5 plus 1 to 5, and plus 1 is for 5 to 15, and plus 2 is 16 to 25, plus 3 is 26 to 20, 50, plus 4 is more than 50, and hyperpoint is plus more than plus 4 now.
Okay. Thanks, Chetan. Please go on.
Thank you, ma'am. Pupil is sluggishly reactive on direct reflex and indirect
You
reflex
wrote
of right
round.
eye.
Here your pupil is round. In
Ma'am,
your
right eye
image,
is
it
round,
is
ma'am.
irregular. Left eye. Okay. So go back, previous slide. So AC is cells, flare. Can you tell the grading of the flare?
Ma'am, standardized debate nomenclature classified a flare into faint, moderate, marked, and intense with fibrin. Faint means there is nil flare, traces of flares present, and moderate is iris details are clear, but marked is iris details are hazy. Whereas intense with fibrin is there is no details of iris present.
So you have written the KPs are in the Arts triangle, and then there
Yes,
is
ma'am.
a diffuse endothelial dusting.
Yes, ma'am.
So is it present all over the endothelium or only in the Arts triangle?
Ma'am, KPs of most of them are present in the Arts triangle, ma'am. But some KPs are scattered other than Arts triangle.
So the total endothelium, there is a dusting. Now, what are those conditions? You will see a diffuse dusting. Usually,
Ma'am,
it is in the inferior part.
Diffuse endothelial dusting is seen in few cytopenic cyclitis or acute
What kind
viral
of KPs do you see in fuchs?
diffuse stellate white KPs, ma'am.
So that kind of picture you have seen?
No, ma'am, not
No.
that kind of picture.
Okay. You told that hypopyon is there is no shifting.
Yes, ma'am.
So where do you see a mobile hypopia?
Ma'am, shifting of hypopyon is seen in the Behçet disease, ma'am.
Why?
Because of there is no fibrin content in the AC, ma'am. There is no fibrin, ma'am. Because of no fibrin in the AC.
Okay. Okay. Continue your presentation.
Lens is not seen clearly, and gonia was not done because the patient is not cooperative for gonia and dema. We have done the gonia after 3 days. The angle are normal. This is the diagrammatic picture showing the Franklin cross section. Fundus examination with the direct distance ophthalmoscopy. Left eye show the red glow present with media with 90D plus 90D and IDO show indirect ophthalmoscopy showed hazy view. Pupil was not dilating. This kind of first order results were made out hazily. Macular details are not clear and background retina is hazy. To summarize, a 13-year-old boy came with the sudden onset of pain, photophobia, watering in left eye of 4 days duration, associated with the knee pains of 1 month duration, with the family history of arthritis. On examination, left eye has a grade 3 plus cells with hypopyon with fibrin in the pupillary area. With these above findings, my provisional diagnosis is left eye acute non-granulomatous anterior uveitis, probably juvenile idiopathic arthritis associated.
What evidence you have about arthritis?
Sir, patient has a history of knee pain, bilateral knee pain, and there is a family history of grandmother having a rheumatoid arthritis, sir.
Grandmother has rheumatoid arthritis, so you diagnose him as arthritis.
No, sir. Through the history, being a 13-year-old boy presenting with the acute and uveitic symptoms with associated knee pains, my
See, the whole diagnosis is the case is there with you for only 4 days.
No.
Sir, sorry, sir.
Usually in Still's
Sir, go ahead.
disease, small joints are involved, no?
Sir, there is two types of arthritis are associated. There is oligoarthritis and polyarthritis. Sir, if the patient is having less than 4 or less, it is considered as oligoarthritis. If it is more than four joints are involved, polyarthritis, sir. In my case, it is only 2 joints, bilateral knees is involved, and age group is around less than 16 years, male being the gender. My provisional diagnosis is juvenile idiopathic arthritis associated anterior uveitis, sir.
Now, did you do the rheumatoid factor? What investigations did you do?
Yes, ma'am. We have sent the investigations, ma'am. Basic investigation starting with the complete hemogram with ESR raised and total count is slightly above the normal limit. ESR is 65 millimeters in first hour, and RF is rheumatoid factor is negative. ANA comes out to be positive, and HLA B27 comes to be positive. MON2 IGRA negative, chest X-ray within normal limit.
So what is the uveitis associated with HLA-B27?
Acute non-granulomatous anterior uveitis, ma'am.
Do you know that, excuse me, ma'am? Do you know how does HLA B27 uveitis present? There is a typical picture of HLA B27 uveitis.
Yes, ma'am.
What is that typical picture?
Ma'am, typically they are presenting with the small to medium non-granulomatous keratic precipitates on the corneal endothelium.
No, that is not the typical picture. A hemorrhagic membrane is seen.
Okay.
It's a severe uveitis, not a mild uveitis like this.
Okay.
And you said, so can you elaborate about white uveitis?
Yes, ma'am. White uveitis is seen in conditions like masquerades with the tumor cells and in aphakic patients with post IVT injections and ghost cell glaucoma with erythrocytes
No,
in the AC.
you are only telling the causes for pseudohypopia.
White uveitis. I asked about white uveitis.
White uveitis is seen in Fuchs syndrome. Fuchs
No, no,
uveitis.
no. Only two causes. So, as you said, juvenile rheumatoid arthritis and spillover uveitis in case of pars planatis. So, in those two cases, you will see white uveitis. And did you take the history of trauma here?
We took the history, ma'am. There is no history of trauma, ma'am.
Usually, a child, a 13-year-old child, will be afraid of parents and he will not disclose. So, by seeing the picture, it seems to be a simple uveitis because within 2 to 3 days, but the only thing is hypopan. It is not seen in traumatic uveitis unless it is an infective one. So the only hypopan is a negative point to say that it is a traumatic uveitis. So you said HLA B27 positive, but that is not related to JRA, isn't it? Is it related?
It is related, ma'am. In 40% of patients having HLA-B27 will be presenting with the anterior uveitis associated with the
Yeah,
J.
HLA B27 it is associated, but juvenile arthritis, what is the how it is inherited? What is its association with HLA?
It is
So HLA
autosomal recessive.
B27, either it presents as acute anterior uveitis or,
Okay.
and also, so when there is HLA B27 positive, so which X-ray you should prefer?
Sacroiliac joint
Joint.
X-ray, ma'am.
Did you do that?
No, ma'am.
So it may also present as acute uveitis too. So that is
Yes, ma'am.
one possibility also.
Yes, ma'am.
But it cannot be associated with juvenile arthritis. Okay. Madam, continue, madam. Tarisha, madam.
So, after doing the investigations, do you want to change your diagnosis now?
No, ma'am. It came out to be highly positive for HLA-B27 and 4+ positive for the anti-nuclear antibodies, ma'am. I stick with my diagnosis, so provisional diagnosis, but my differentials were traumatic uveitis and endophthalmitis variant of toxocariasis.
How will you rule out a traumatic uveitis?
In case of traumatic uveitis, there will be a history of trauma, blunt trauma to eye, and on examination, corneal epithelial defects might be present, and traumatic iritis, traumatic uveitis might be present. Due to inflammation, there will be a rise of IOP, traumatic inflammatory glaucoma will be present, and uh, cells in the AC and hypema might present, ma'am.
Traumatic glaucoma. So how there
Inflammatory
is a
glaucoma, ma'am.
glaucoma? What is the cause
Due
of that
to
glaucoma?
Due to inflammation, there is a inflammatory debris blocking the trabecular meshwork and raising the transient IOP during initial days.
No, in a case of trauma.
Yes, ma'am. In case of trauma, there will be a inflammation due to trauma, and uh, after that, there is a inflammatory debris clogging the trabecular meshwork, which is causing the resistance to the outflow of the aqueous humor and raising the IOP.
Are there any other mechanisms? That is what I'm asking. There is a trauma.
Yes, ma'am. Angle
What type of?
recession, angle
You
recession
have to
might be
look
there.
for angle recession
Angle recession,
glaucoma,
yes.
or you have to look for a hyphema.
Yes,
But
ma'am.
you told the
Hyphema.
hypopion is 1/4 of the anterior chamber.
Yes, ma'am.
So what is the grading of this? So 1/4. So what are the other causes? So how did you rule out endophthalmitis?
Um, because there is no history of pets in the house, ma'am. Basically, endophthalmitis variant of ocular toxocariasis will be spread by the pets, and causative agent is Toxocara canis. and there is no history of petting in the house. And other my patient fundus is appear normal, man. But in case of endophthalmitis, there is a severe vitritis and retinitis involved, and spillover anterior uveitis will be there, ma'am.
Okay. So what treatment did you give for your patient?
Ma'am, initial on the presentation, I have given hourly topical prednisone acetate for 3 days and cycloplegics with mediatics homemade 2% TID for 3 days. After that, we have shifted the patient to the tropical medicine.
So prednisolone only for 3 days.
Ma'am, hourly prednisone. Ma'am. Afterwards, we have uh, tapered, ma'am, 6 times for 2 weeks.
Okay.
How was the KPs on the first day?
When
You said
KPs
5
were, sorry, ma'am.
Yeah. Proceed. Good.
Yes, ma'am. KPs, these are arranged in the orange triangle with the small to medium size KPs, ma'am.
In the color of the
Non-granulomatous
KPs?
KPs.
The color of
White,
the
ma'am.
KPs? White. Okay.
White
So
creamy.
okay, where do you see the KPs? All over the cornea. In which condition you see the KPs in all over the cornea?
Yes, ma'am. KPs diffuse KPs were seen in case of Fuchs heterochromic iridocyclitis syndrome.
Yes.
What type of KPs
other
you see in a viral infection?
Ma'am, in case of viral infection, we'll see pigmented KPs, ma'am.
Pigmented KPs are old KPs. Viral? How does a viral KPs? Where are they located?
Ma'am, we'll see coin-shaped KPs in case of CMV virus, ma'am. These are located in the Alls triangle. In case of Fuchs, it is located diffusely, ma'am.
No. In a case of viral, they are seen more in the center. Okay.
So, otherwise, they may be diffuse all over the
Diffuse
cornea.
also.
Apart from that, and sarcoidosis also, you'll see the KPs all over the cornea.
Okay.
So what are the complications of this condition? You told juvenile rheumatoid arthritis. What complications will you expect?
Complication of uveitis is untreated uveitis is band-shaped keratopathy and posterior synechiae 360 degrees and occlusal pupillae, iris Bombay formation and angle closure and cataract, uveitic cataract and glaucoma and cyclitic membrane formation over the ciliary body leading to phthisis bulbi.
So that should be in an order. You said first band-shaped keratopathy. So when do you see band-shaped keratopathy? When the eye is
That is
not
fine at
functional.
last.
Not functional. So,
Okay.
so you have to start with cataract. Then in the last, it said band-shaped keratopathy, phthisis, like that. So it should be in that order, from
Yes.
simple complications to blinding ones. Okay.
Yes.
Then
So you told there is a cataract. So if
Yes.
there is a cataract, so how will you manage this?
Ma'am, for managing cataract, the patient should be quiescent for at least 3 months free of uveitis, and under the cover of steroids, topical steroids, we'll do the management of cataract by cataract surgery, ma'am. And post cataract surgery, patient should be on steroids for the longer period.
So in these cases, usually IOLs, what type of IOLs are used in case of uveitis?
Rigid lens.
Uveitis. They are usually in uveitis there we use a heparin coated IOLs. But in these children who are having juvenile rheumatoid arthritis, IOLs are usually we don't put because there is chances of this stysis. So IOLs, even if there is a cataract also, I don't think IOLs are contraindicated in these cases. Okay. So you have to do a follow because it is a small child, 13 years. Okay.
You said glaucoma. You wanted to rule out traumatic glaucoma. So angle recession. When do you usually do a gonioscopy?
Gonioscopy will be done when
After trauma.
gonioscopy will be done when all the fibrin AC is free of inflammation. We'll do the gonioscopy, ma'am.
So that is approximately around 6 weeks.
1 week.
So after 6
okay.
weeks.
Okay.
So not immediately. After 6
Okay.
weeks, you will do gonioscopy and evaluate for the causes of glaucoma. Look for the angle recession. So otherwise also you have to advise the patient if it is a trauma, you have to advise the patient regarding angle recession and
Angle recession.
follow. Need for the follow.
Yes, ma'am. Yes, ma'am.
So after how many days you have to follow in a case of traumatic glaucoma?
Ma'am, in case of traumatic glaucoma, we have to follow every 8 weeks, ma'am. 6 to 8 weeks.
No, after 6 to 8 weeks, if after you have to rule out angle recession, and if you find angle recession, you have to follow every year, actually yearly.
Okay.
Dr. Chetan, why did you give homide? Why can't I give tropicamide? Can I give tropicamide?
Sir, yes, sir. We can't give tropicamide in these cases because this posterior synechiae will be broken with the higher cyclopedic mydriatis, that is atropine 1% or homide 2%. Post synechiae, when they are broken, we can shift the patient with milder mydriatics like tropicamide, sir.
So what is the role of a cycloplegic? One you told about the Sinike. Are there any
Yes,
other
ma'am.
That's the only
uses of
reason?
No, no, ma'am. No, sir. Cycloplegics, they play a main role in relieving the severe spasms so that the patient is free of pain.
So it
So why
gives
can't I give?
rest to the.
Sorry, why can't I give cyclopentalate?
Sir, cyclopentolate is not given in the case of uveitis because this drug is a chemotactic, sir. It will attract the chemokines and there is a high chances of inflammation, sir.
Can I give atropine? Why did you choose
Yes, sir.
homotropin? Why not atropine?
Yes, sir. If we give atropine 1%, its effect stays for a longer period, approximately 5 to 7 days. So if a patient is dilated for 5 to 7 days, there might be a high chance of forming a synechiae in the dilated position of the patient. So
What
we
is the
shift
duration of action of atropine?
1 week now.
1 week.
Mydriasis and cycloplegia, both you have to take.
Yes, ma'am. Yes, ma'am.
No, they differ usually.
Mydriatics is for 1 week, ma'am. Cycloplegics is 3 days.
3 days,
No,
3
cycloplegia
weeks.
is more than that.
It
2
is
weeks.
about 3 weeks.
3 weeks.
Okay, 3 weeks.
Around 20 days.
Yes.
What was the intraocular pressure in this case?
Sir, in this case, it is 12 mm Hg, sir. 12 mm
What if
mercury.
the intraocular pressure is about 25? What will you do? 13-year-old.
Sir, 13-year-old, first I'll rule out the traumatic history. If a trauma is not there,
Everything
I'll
is
put a
ruled out.
patient.
You have diagnosed anterior uveitis.
Yes, sir.
Intraocular pressure is 25. What do you want to do?
I'll ask the history of whether the patient is having asthma or not. I'll put him on anti-glaucoma medication, sir.
What medication?
Iovate, Bidoxolol, sir.
What medicine you don't want to give in uveitis?
Sir, yes, sir. I would like to avoid the prostaglandin analog, sir, because it causes inflammation, sir.
Okay.
And
Yes. Yes,
as
madam.
sir is asking, what are the how does the intraocular pressure vary in a case of uveitis? And what are the different mechanisms leading to that?
Yes, ma'am. In case of uveitis, there is various mechanisms by which IOP will rise. One is clogging of the trabecular meshwork with the inflammatory debris. Another one is in case of viral uveitis, there is a trabeculitis, and in case of inflammation, there is inflammatory shock to the ciliary body, which is leading to the reduced production of aqueous humor. Low IOP will be there.
Also,
So
initially
even the
pouring in
cyanic,
more pouring in of uh, exudates are there. So that's why also it increases. And as madam said, occlusion people and seclusion people.
Chetan, what
And
is the role
PAS,
of
PAS
steroid
also.
sparing treatment?
Sorry, sir.
What is the role of steroid sparing treatment?
Yes, sir. If the patient is responsive for the steroids, we'll go with the steroid sparing treatment uh, antimetabolites and alkylating agents, T cell inhibitors and interleukin inhibitors, and TNF alpha inhibitors and interferon, sir.
So what will you do if this patient is a steroid responder?
Yes, sir. If this patient is a steroid responder, prefer to I'll refer to the rheumatologist who will write for the immunosuppressants, sir.
How will you
Immunosuppressants
grade
in
the
Other,
a
steroid
13-year-old
responder?
boy?
sir,
Tarak sir, you're asking something.
How will you grade the steroid responders?
sir, steroid responders are graded into three types, sir. Mild responders within 1 week, within 2 weeks of patient prescribed with the topical steroid. If there is a hike of IOP with 5 to 10 mmHg, they are called as mild responders. Intermediate responders are for 10 to 15, and more than 20 is severe responders.
Less than 4 is poor, more than 15 is high responders.
Yes, sir.
Why people is small in this case?
Sir,
Uveitis?
because yes, sir. In case of uveitis, there is a inflammation of iris causing the boggy iris and inflamed iris. It will make the pupil small, sir.
Why, sir? Why it causes small?
Due to boggy iris, sir, the swollen
Boggy
iris.
iris is responsible for sluggish reaction, not for small people.
Okay.
because of the toxins which are released, okay, so that will cause a meiosis. It is all waterlogged, the tissue is.
Toxins also stimulates both the sphincter people and dilator people, but sphincter is stronger than the dilator. That's why people will constrict it. And boggy iris is due to that causes for sluggish reaction of the people. Okay. How the hypopain is formed?
Sir, hypopania is formed because of the layering of inflammatory cells poured into the anterior chambers, sir.
How?
Due to inflammation, sir, into the anterior chamber, the inflammatory cells like polymorphonuclear cells and lymphocytes are poured into it. After some time, they form a
Because
layer
of
by
this
layers.
No, no.
inflammation, the permeability of the vascularity changes, no?
So you have to talk about the barriers,
That's
breakage of the
Okay.
ah,
Blood aqueous barriers.
aqueous barriers. Okay.
Yes, sir. Yes, sir.
Then what is the cause of the defective vision in your case?
Ma'am, in my case, the cause for defective vision is cells in the AC and flare, and pupil is small.
Okay. So what are the other causes of defective vision in a case of iridocyclitis?
Ma'am, other cause of defective vision in case of iridocyclosis or cyst and macular edema, which is the main cause of defective
Why
vision.
don't you start
And,
from the cornea and
Start
go back?
from the anterior to the posterior.
Start from the cornea.
Cornea, it is the keratic precipitates, and in the ASC there is a cells
Now,
and flare
corneal
present,
edema
and
is there, corneal opacities are there. Okay, so ground glass cornea.
okay.
Hmm.
Ground glass cornea, and in the ASC there are cells and flare fibrin present, and there are the posterior synechiae present over the lens, which is causing the restriction of pupil, and there might be a presence of cells in the anterior vitreous space, and
What happened
there
to
is
the
chance
lens?
lens
A membrane over the lens, iris also, membrane over the iris, pupil.
What is occlusio pupillae? What is seclusio pupillae?
When occlusio pupillae is when the synechiae is present 360 degrees over the lens, and seclusio pupillae is over the 360 degrees over the lens, and occlusio pupillae is 360 degrees of synechiae along with the membrane, which is causing the occlusion.
Hmm. So, what is the cyclitic membrane? Where is it located?
Cyclitic membrane is located over the ciliary body, ma'am. Due to chronic inflammation, the membrane forms over the ciliary body.
So, it is present behind the lens and then it grows on to the ciliary body.
Okay.
Okay, so what is the type of cataract seen in a case of uveitis?
Yes, ma'am. In case of uveitis, we'll see a posterior subcapsular cataract, ma'am.
Why? Why it is seen only in the posterior subcapsular area?
Due to seepage of toxins and inflammatory mediators into the from the anterior capsule into the posterior side, ma'am.
Why
So
there is no
posteriorly,
anterior capsular cataract? Why only it is there in the posterior?
ma'am, because of presence of anterior capsular epithelium, they'll pump out all the
There is a
toxins.
high metabolism in the
Yes,
anterior
ma'am.
capsule. So that will
Yes,
not
ma'am.
allow the toxins to settle there. Okay.
Yes, ma'am.
So what are the other features of a complicated cataract?
Complicated cataract. Other features are polychromatic luster present, and there are
Breadcrumb appearance. Yellowish
yes,
hue
ma'am.
is there.
Blood cup appearance and lesions.
Okay.
So regarding the treatment, why did you prefer prednisolone acetate?
Ma'am, with the prednisone acetate, in case of uveitis, the inflammation is
No,
we
that
can
is
bring
not
down
the
the
reason.
inflammation.
Do
So
you
does
want
it
to add
penetrate
some
fully?
antibiotic or not? Along with your
No,
steroid, should you have added an antibiotic? Always we give antibiotic along with the steroid. Some combination drugs we use usually, no?
So that's what I'm asking. Why didn't you use the dexamethasone along with antibiotic? Why did you prefer prednisolone? So prednisolone causes, it doesn't cross the cornea. It causes less IOP spike. That's why we prefer prednisolone acetate rather than dexamethasone. So usually topical antibiotic, I think, madam, it has no role here unless it is an
To
infective cause.
prevent some secondary infections.
Yeah.
Usually, maybe it is an infective
So that's
origin.
why dexamethasone usually is not preferred.
No,
So
no, I'm
prednisolone
talking
does.
about antibiotic. Some gatafloxacin or something we used to add because maybe it is some kind of infective.
Right.
Okay, good presentation. He has answered
thank
almost
you.
more of most questions. Good
You can stop
presentation,
sharing, Dr.
Chetan.
Chetan.
So, madam, passing.
Pass, sir. Both students pass, sir.
Both,
Sir,
both are
somebody was
possible.
asking about intravitreal steroids. What are the other modes of treatment like? So if there is CME,
Stop
Yes,
sharing. Yes, madam is asking about intravitreal steroid.
Yes, ma'am. We can give intravectal dexamethasone and intravectal IVTA, ma'am. Transline acetate we can give, ma'am.
No,
In
no,
case of
madam is asking, are there any other routes of administration? If there
yes,
is a
ma'am.
CME near the macula, you can give some
Okay.
injections.
Yes, ma'am. Posterior subcutaneous
Yes, that is what
transline
madam is.
can.
Yes.
I think we have come to the end of this. Thank you very much, all the examiners, especially Dr. Sirisha, Dr. Nasu, and Dr. Nivedita has taken an active role today. She is bombarding him with all the questions.
No,
Nivedita madam, good evening.
Better now.
After a long time.
Thank you, Dr. Tarkesh Rao, for your active participation, and we have two mentors who are mute spectators today. Their students have done very well, so they didn't have any role. Dr. Danya and Dr. Kailan Raju. Both your students have done really good. I'm very happy about this. This is definitely, this sort of an interaction is very useful for all the postgraduates who are watching these videos, because there is nothing else any examiner can ask other than the questions that are asked here in this. There's nothing else is there in the subject. And Dr. Ansu has covered the orbit the topic very well, especially all the classifications and all. And I thank Andhra Pradesh Ophthalmological Society for giving us this opportunity to present the short cases webinar, and we are going to do this every last Friday of every month. I want all your students to come forward and present the cases in this short cases webinar. Because this is going to be a very good opportunity to face not your own institute process, but process from other institutes. This is a very good opportunity to face the examiners. With this, I think I'll conclude the session for today. Thank you all very much and have a good night.
Thank you, sir.
Thank you, sir.
Thank you.
Thank you, sir.
Thank you, sir. Thank you, madam. Thank you.